Okay, so now we're going to go over how to manage exacerbations within the home setting and also within the urgent and emergency care setting. So let's start with home setting. So you want to incorporate 4 main components of care, include assessment and monitoring, patient education, environmental control, and medications. Develop a written asthma action plan. Instruct patients how to recognize early signs, symptoms, peak expiratory flow measures that indicate worsening of asthma, which is very important. Adjust medications. You may want to increase the SABA, and in some cases add oral systemic corticosteroids. And remove or withdraw from environmental factors that may contribute to an exacerbation. Monitor response and seek medical care if there is serious deterioration or lack of response to treatment. Now, we're going to discuss the management in urgent and emergency care settings. Assess severity, treat to relieve hypoxemia and airflow obstruction, reduce airway inflammation, discharge with medication, and patient education. So treatment strategies include assessing initial severity by lung function measures for ages greater than 5, and symptom and functional assessment. Provide supplemental oxygen, repetitive and continuous short-acting beta-2 agonist, oral systemic corticosteroids, monitoring response with serial assessment of lung function measures, using pulse oximetry, and looking for symptoms. Considering adjunctive treatment, magnesium sulfate or Heliox in severe exacerbation, or if unresponsive to treatment. So, at discharge, you want to provide medications such as your short-acting beta-2 agonist, oral systemic corticosteroids, and consider initiating ICS. Refer for a follow-up visit. An emergency department asthma discharge plan should be provided to the patient. Review the inhaler technique whenever possible, and watch the environmental control measures. So now we're going to go over some differential diagnostic possibilities for asthma. Infants and children. Upper airway disease, allergic rhinitis and sinusitis, obstruction involving large airways, foreign body in the trachea or bronchus, vocal cord dysfunction, vascular rings or laryngeal webs, laryngotracheal malacia, tracheal stenosis or bronchial stenosis, enlarged lymph nodes or tumor, obstructions involving small airways, viral bronchiolitis, cystic fibrosis, bronchopulmonary dysplasia, and heart disease. Other causes: recurrent cough due to asthma, aspiration from swallowing mechanism dysfunction, or what people refer to as GERD, gastroesophageal reflux disease. In adults, chronic obstructive lung disease, or COPD, generally chronic bronchitis or emphysema, congestive heart failure, pulmonary embolism, mechanical obstruction of the airways, benign or malignant tumors, pulmonary infiltration with eosinophilia, cough secondary to drugs, and vocal cord dysfunction. A differential diagnosis of asthma should be considered. Recurrent episodes of cough and wheezing most often are due to asthma in both children and adults. However, other significant causes of airway obstructions leading to wheeze must be considered both in initial diagnosis and if there is no clear response to initial therapy. Additional studies are not routinely necessary but may be useful when considering alternative diagnosis.